هيكلمنا على الجلسة ديت يعني دكتور أيمن هي الجلسة الثانية هتبقى Pharmaceutical Symposium by Boehringer Ingelheim.
Okay. Sincere thanks to my co-chairman and Professor Magdi also. This is a Pharmaceutical Symposium by Boehringer Ingelheim. We have two speakers, and it's my pleasure and honor because both are my deepest friends and colleagues. And as usual, we start by ladies first, and also to give Majdi a chance for second wind and to warm up. So we'll start with Professor Samiha Ashmawi. All of us know her. She's a professor of pulmonary medicine at Ain Shams University. Professor Ashmawi تكلم عن would anticholinergic fill a gap in asthma management. دكتورة سميحة. شكرا.
Before starting, I'd like to thank Professor Tariq Safwat and the organizing committee for this very nice meeting. And I also would like to thank Boehringer Ingelheim for inviting me to share in this meeting as well. And my presentation today will be concerned with the use of anticholinergics in bronchial asthma. And to start with the prevalence of asthma. Now, the prevalence of asthma and allergic rhinitis among school children has been studied in different Arab countries, and they found that as regards the symptomatology, it was highest in the Saudi Arabia, and it was least in Morocco, 4.4%. Now, regarding the situation in Egypt, the prevalence of physician-diagnosed asthma in school children aged 11 to 15 is about 9.4%, and asthma presented as a third leading diagnosis with estimated diagnosed patients of more than 1.5 million patients. Now, what about the AIR study, which is asthma in reality in the Gulf and Near East? These were the countries who joined in the study: Lebanon, Jordan, Kuwait, Oman, United Arab Emirates. And the results of this study regarding those patients who had to go to the emergency visits during the past year, the highest was in Kuwait, 89%, and the least was in Lebanon. But it must be emphasized that all over the country, all over the world even, in different countries, they made these studies to see the symptoms in daytime and nighttime symptoms, and they found that it was very, very high in Turkey, about 92%, and maybe the least was in Asia. But just to signify, this signifies that the symptoms were more overwhelming than the subjective feeling of the patients themselves. So they also found that about 30 to 60% of patients remain not fully controlled on LABA and ICS, and this is very alarming. So we must know that we concluded that the level of control in the Middle East is not optimum, and despite the current treatment options, in particular the ICS and LABA, at least 40% of asthmatic patients still experience symptoms and could benefit from new treatment options. So, will anticholinergics fill the gap in asthma control? This is an important question that we have to find out ourselves. There were several studies that were carried out all over the world. According trying to identify whether tiotropium respimat, which is an long-acting anticholinergic, could be of use in bronchial asthma. And they, in certain countries, as for example, it was approved the use of tiotropium respimat in asthma, and in Chile, Colombia, Ecuador, Thailand, and Russia. And the asthma indication has been accepted in Europe. So the respimat is indicated as an add-on maintenance bronchodilator, and this is very important, an add-on treatment in adult patients with asthma who are currently treated with the maintenance combination of inhaled steroids and long-acting beta-2 agonists, and who experienced one or more severe exacerbations in the previous year. We have various studies, but one of the important studies was done by Bateman, and we all know Professor Bateman, and of course with his colleagues. And it was tiotropium is non-inferior to salmeterol in maintaining improved lung function in B16 arginine patients with asthma. This study comprised about 388 moderate asthmatics homozygous for B16 arginine, and the B16 arginine asthmatics were hypothesized to potentially not benefit from short-acting beta agonists or long-acting beta agonists. However, new evidence suggests that such pharmacogenetic variation does not exist. And all the patients in this study were on ICS maintenance therapy, high dose. Salbutamol MDI was permitted as a rescue medication all throughout the study. Now, what about the study design? This study comprised about 400 cases. Now, 1/3 received placebo and 1/3 received tiotropium 5 micrograms once daily, and the third group received salmeterol twice daily. Now, it comprised a run-in period of 4 weeks, and then 16 weeks treatment period, and then a follow-up period of 4 weeks again. Now, what about the results? Well, first, the inclusion criteria were that documented history of asthma, pre-bronchodilator FEV1 equals or less than 80% predicted, patients not on LABAs in the prior year, or a pre-dose FEV1 equals or less than 90 predicted for patients on LABAs in prior 3 months. FEV1 increase of 12%, that is a reversibility is occurring, and smoking history less than 10 pack years and 1 year at least smoking cessation. Now, this shows the basic characteristics of the cases. They were almost all 44, the tiotropium group, and salmeterol 42, and the duration of asthma in all were about 17 years, 18, ranging from that. Now, they all showed in the more or less the same as regards the placebo tiotropium, about FEV1 to predicted 68%, and the FEV1 percent change from post-bronchodilator value that it showed reversibility occurring in all the cases. Now, what about the results of this study? As we can all see that there was a statistically significant increase in those who took or received salmeterol, that's the blue one, and tiotropium, that's the green one, a statistically significant increase as regards the mean peak expiratory flow compared to the placebo, a great difference which is very, very evident up to the 16 weeks and even in the 4 weeks of follow-up. Now, what about the adverse events as regards this study? There were no serious adverse events, maybe 1 in the placebo, 2 in tiotropium, but even 7 in the salmeterol group. More adverse events, more or less the same. There was nothing striking. Even just the nasopharyngitis was maybe the most striking, but it occurred more in the placebo group when compared to the other groups. So they were more or less comparable side effects. So to conclude in this study that tiotropium was more effective than placebo and as effective as salmeterol in maintaining improved lung function in B16 arginine patients with moderate persistent asthma. This was in 2011. There was another study carried out by Kirstens et al. And this also was an important study which tried the tiotropium in cases of severe uncontrolled asthma. And we're gonna see now the results of the study and the study itself. Now this is the study design. This study comprised about 100 cases divided also in 3 groups, starting with a 2-week run-in period. All cases received ICS and LABA at the beginning for 2 weeks, and then they started adding one of these 3 protocols, whether placebo for 8 weeks, then tiotropium 10 micrograms once daily, or, and then later on after 8 weeks, tiotropium 5 micrograms for another 8 weeks. A total of 24 weeks, and then 3 weeks follow-up. This was the second group, and this was the third group. Now the inclusion criteria in this study: asthma history of 5 years duration confirmed by bronchodilator reversibility or bronchial hyperresponsiveness. FEV1 equals or less than 80 predicted post bronchodilator, FEV1 over FVC 70% or less, smoking history less than 10 pack years and more than 1 year smoking cessation, asthma control questionnaire score more than 1.5, and 4 weeks treatment with stable high dose ICS and LABA. This is the baseline characteristics of the cases. There were more or less, they were first 107, but only 100 completed the study, and they were divided into the 3 groups as I've just mentioned before. Mean age about 54.8 and mean bronchodilator 58, the FEV1 58%. Now, it was allowed that the patients would take ICS. Of course, all of them took the ICS and LABA, but also they were allowed to take the beta-2 agonist short-acting, or short-acting anticholinergics were not allowed in this study. Thiophyllin was allowed, antileukotrienes, and also antihistaminics were also allowed in this study. Now, what about the results of this study? Now, as we can see here, the mean FEV1, if we look at this, this is the placebo, this is the tiotropium, 5 micrograms, and this is the tiotropium, 10 micrograms. They're almost the same. I mean, they were comparable results as regards the FEV1. Not only that, but also the forced vital capacity, it showed almost the same. They were comparable. Whether the dose was 5 micrograms or 10 micrograms, it didn't matter much. But there was a statistically significant increase when compared to the placebo group. This also showed that the superiority of using the tiotropium, it showed statistically significant increase as regards the peak FEV1, not only the peak, but also the trough FEV1. Now, what about the adverse events in this study? They were also more or less comparable, except for the dry mouth. If we look up here, it was 1 in the placebo group. Those who received the 5 micrograms, it was about 2 cases, but in the group who received 10 micrograms, they had dry mouth, they were 7. So this was just as an adverse event. They considered it an adverse event. So it was preferable to give the 5 micrograms then. So to conclude from this study that the addition of once daily tiotropium to maintenance therapy with high dose ICS and LABA, so it's an add-on treatment, results in significantly improved lung function in patients with severe uncontrolled asthma who remain symptomatic and obstructed despite optimal therapy. Adverse events were balanced across groups except for dry mouth, as we saw together, which was more than common on 10 micrograms of tiotropium. So in severe asthma patients still symptomatic despite high dose ICS and LABA, the addition of tiotropium significantly improved FEV1 and FVC as well. This is the final study, and this was done in 2012. So it's a more recent study. And the study design, this study consisted of 900 cases in which they were screened for 4 weeks. And then they were divided into 2 groups, tiotropium receiving 5 micrograms once daily in the morning, and the placebo group. And the study continued till 48 weeks and then a 4-week follow-up. There were 2 identical trials in this study. All patients were on ICS and LABA. This is very important. And the co-primary endpoints were the FEV1 peak after 24 weeks of using the drug. Not only the peak FEV1, but also the trough FEV1 after 24 weeks was very important. And the time to first severe asthma exacerbation in pooled analysis after 48 weeks. This study was carried out in 117 centers in 5 continents, so it was a worldwide study. Now, the cases asthma were diagnosed less than 40 years, whether documented by bronchial hyperresponsiveness, peak expiratory flow, 5-year history of asthma, the age from 18 to 75, never smoker or ex-smoker, 1-year cessation, and less than 10 pack years. In the uncontrolled severe cases, despite ICS and LABA, mandatory high-dose ICS more than 800 micrograms budesonide plus LABA, they were given, they were permitted to take thiophylline leukotriene modifiers and so on. And also, the asthma control questionnaire was more than 1.5 at the screening and baseline visit. And the presence of post-bronchodilator FEV1 less than 80%. And at least 1 severe asthma exacerbation in the previous year treated with systemic steroids. Now, as we can see here, that the current age was about 52, and the age of onset about 26 in all the groups total, and the median duration about 28 years, duration of asthma. Now, the bronchodilator effect, these were the drugs that were allowed to be used. It's, as I mentioned them previously, and the primary endpoint in this study, the peak FEV1 from 0 to 3 hours at 24 weeks, both trials. We said there were 2 identical studies. The trough FEV1 at 24 weeks for both trials, and the time to first exacerbation at 48 weeks. Now, what about the results of this study? As regards the trial 1, we can see here that there was a statistically significant increase in the group, in the FEV1 in the group who received the 5 microgram tiotropium when compared to placebo group. And this shows that the importance of the significant increase which was present in the peak FEV1 and the significant increase in the trough FEV1 in the group who received tiotropium for the 24 weeks. Now this is for trial 2 and it's almost identical. It also shows a statistically significant increase in the group who received tiotropium when compared to the placebo group. Also significant increase in the peak FEV1 and the trough FEV1 as well. Now, definition of severe asthma exacerbation was the need for initiation or doubling of systemic corticosteroid therapy for at least 3 days. This is an ATS-ERS statement. The time to first severe exacerbation, this was another endpoint, and the pooled analysis over 48 weeks. Now, what about this study? What about the risk of exacerbations? There was a 21% reduction in the group who received tiotropium 5 micrograms, 21% reduction in the risk of asthma exacerbations. Now, what about the secondary endpoints? Now, what about asthma worsening? It is 1 or more asthma symptoms outside the patient's usual range of day-to-day asthma that lasted for at least 2 consecutive days, and or a decrease of the patient's best morning peak expiratory flow of 30% from the mean morning peak expiratory flow for at least 2 consecutive days. Also, it includes severe exacerbations, time to first episode of asthma worsening, and a pooled analysis over 48 weeks. And as regards the asthma worsening, it fell the risk reduction of 31% reduction of asthma worsening. So of course, this is a very important result. Now, regarding the FEV1 response over the 24-hour profile, we can see this is a 24-hour from 0 hour till 24. There was a statistically significant increase in the FEV1 all through the way, all over the 24 hours, as we can see, when compared to the placebo group. Also, this is trial 2. It's almost identical. Also, statistically significant increase, not only in FEV1, but also in the peak FVC and the trough FEVC as well. This is also trial 1 and 2. And we can see the peak morning FEV1 statistically significant increase when compared with placebo. This is trial 1 and this is trial 2. It is even identical results. Now, this shows the morning and evening response. This is the evening response. It was continuous, meaning to say that the trough FEV1 showed statistical increase and statistical improvement all over the 24 hours, morning and night. Now, what about the asthma control questionnaire? Well, it's more or less comparable in one study, but there was a great difference, a great improvement in the asthma control questionnaire in the group that received the tiotropium. Not only that, but regarding the asthma quality of life questionnaire, also there was a statistically significant improvement in those who received tiotropium 5 micrograms. Now, what about the safety outcomes? As we can see here, it was comparable. Not only that, just even if we compare the occurrence of asthma in all the groups, it was even lesser, much lesser than placebo itself. Now, regarding the adverse events, now as we can see, the total with any adverse events, it was even lesser in the group who received tiotropium 5 micrograms. The severe adverse events, more or less the same. And my final slide shows that for the serious adverse events or fatal adverse events, no events were occurring, but regarding hospitalization required, it was even lesser in the group who received tiotropium. And this was my last slide, and thank you very much.
Thank you. Thank you very much, Professor Samiha. And because we are behind schedule, we'll keep the discussion very short question and very short answer, please. تفضل.
بالنسبة
دكتور سميح.
سؤال بس. بالنسبة للكاردياك ازماتيك بيشنت اللي احنا ما نقدرش نستخدم فيهم غير التايوتروبيا وما نقدرش نستخدم اللابا، هل في هيد تو هيد ترايلز مش اد اون يعني؟ طب هل الكاردياك بيشنت اللي احنا مش هنقدر نستخدم فيهم اللابا؟ بس انا قصدي حاجه اصل احنا في الحالات دي احنا بندي بس يا ابراتروبيوم يا تراتروبيوم في الحالات الكاردياك اللي هم عندهم اي اف يعني كله اد اون مفيش لكن فيش.
Thank you for the question. Second speaker in this session, a never-end story. We like to hear you, مجدي، في مش بس في pulmonary hypertension، مش بس acute exacerbation. Also, we like to hear from you.
Thank you very much, Dr. Hajan. So now I'm going to take the hat of the pulmonary hypertension, having another hat of COPD and respiratory medicine. So COPD, it is another, I think, fascinating disease that we all know very well, and we've been living with it for the last a few decades. So what is the target for treating COPD patient? It's actually pretty much like asthma. A few years ago, we used to talk about COPD treatment as kind of symptoms reliever, improve health status, exercise tolerance, lung function, etc. And for the last, I'll say few years, we shifted gear a little bit and we start talking about different category of target when we're treating COPD and asthma as well. And that is what's so-called reduce the future risk. And if you talk about the reduction of future risk in COPD, to great extent, we talk about prevention and treatment of exacerbation. Hopefully by doing this, you will modify or slow down the disease progression, and hopefully you can improve mortality and survival. Because it's very clear that it is the exacerbation that make COPD patient going rapidly downhill with all the complication and deterioration. And because of the exacerbation is extremely important, the international gold guideline had made kind of subtle but important adjustment to the guideline last year. And that was purely on the level of the exacerbation. Now, in GOLD 2013, when we look at the categories A, B, C, and D, where A, B are low risk for exacerbation, C, Ds are the high risk for exacerbation, in 2013, you needed to have 2 exacerbation at least to be in group C and D. Last year, or actually this year, 2014, the GOLD basically panel did some modification that now even one severe exacerbation leading to hospitalization is enough to categorize the patient as C and D. So again, this emphasizes very interestingly on the importance of dealing with exacerbation when it comes to the COPD patient. Unfortunately, this emphasis on exacerbation was not, if you like, mirror image by any change in treatment recommendations. Still, we recommend the same basically treatment pattern when it comes to A, B, C, and D categories in 2013 and 2014. But we're going to talk about that later on. So let's revisit this exacerbation business. What's the problem with exacerbation? And it's clear if you look at what happened in COPD, to great extent, this is the cornerstone of treatment. Because we know that one of the problems that we face with a COPD patient is the rapid decline in lung function. And it is the exacerbation that is the single most important factor in further rapidly declining the lung function. So those who have more and more exacerbation, they tend to lose much faster lung function. It also increases mortality. And at that two pattern, that become where our treatment should be targeted. Of course, the cost and the quality of life should not be forgotten when we talk about exacerbation per se. Another important point with exacerbation, that it seems that the more severe the COPD, the more exacerbation the patients will get. And for example, if you look at the GOLD 4, this is in the old category. When you have severe COPD based on lung function, you have significantly more milder and severe exacerbation compared to those patients who have less severe COPD, such as GOLD 2 or GOLD 3. So again, the severer the COPD, the more exacerbation you will have. But that's not the end of the story, because even those patients who seems to have mild COPD or stage 2, that is very reasonable lung function, although about 60% of them, they get no exacerbation, about 40% of them will get at least one exacerbation. So those people whom now we call are mild, they are not really immune. They can still get, and about 40% of them will get exacerbation over the last year. And if you look at this BREATHE study, this was, I think, one of the marvelous study that was done in many MENA countries in North Africa and the Middle East, including Pakistan, showed that in those different countries, about 50% of the COPD patients, irrespective of the COPD severity, will get an exacerbation. So the message is repetitive. The exacerbation is common. The exacerbation does happen even in milder COPD patient, and it leads, if you like, to all kind of worsening the outcome of the patient. So how we can prevent this exacerbation? What should we do to prevent exacerbation? One of the interesting part, which I think we are so lucky, that the treatment that we use to treat COPD can modify by themselves the exacerbation rate. And we're going to talk about that in a second. Of course, we should not forget about smoking cessation, vaccination, physical and rehabilitation programs, and of course, there's a lot to say about inhaled steroid, antibiotic, and those who get very frequent bacterial exacerbation. And I'm sure you are aware of the recent data of using a statin in the New England about last month. Unfortunately, statin failed to reduce exacerbation rate in those patients. But that just show you that we are trying to use different treatment categories with one target, is to reduction of the exacerbation. So let's look at the guidelines and how the guidelines helps us, if you like, to modify our treatment towards this target. If you look at category A, and those category A, they're supposed to having very low symptoms and very low risk of exacerbation. So those are the best categories. And if you look at the guidelines talk about at the first choice to use either short-acting anticholinergic or short-acting bronchodilator as a PRN. However, there is now some says that maybe even those patients, we should start treating them with more appropriate therapy, such as LAMA or LABA. because we know that COPD is progressive disease in general, and if you allow those patients to be left with no treatment, those patients will probably get to much higher basically categories. And not only that you need always to understand that, as I showed you before, those patients are not immune from exacerbation. But because exacerbation is not very common in those groups, most of the studies try to address other endpoints. For example, the UPLIFT study using tiotropium in those patients who were treatment naive, so they're supposed to have mild COPD. And we look at the quality of life, for example, you can see that quality of life in those patients improved significantly with tiotropium compared to placebo by dropping of the St. George Respiratory Questionnaire by more than 4 points, and that's clinically meaningful, basically improvement. What about category B? Now you have a little bit of more symptoms, but still you have very low risk for exacerbation. And now the guidelines talk clearly about that you should start having the standard treatment, LAMA or LABA. Started with LAMA or LABA, or you can, in those patients who have more symptoms, you can combine the two drugs. And when you look at the data, again, the endpoints in this category did not focus specifically on exacerbation because, as I told you, those groups have low risk for exacerbation. But looking at quality of life using St. George Respiratory Questionnaire, tiotropium was very effective in improving quality of life, improving the dyspnea index scoring by improving the score by more than 1 point, and that was with the clinically meaningful, and, which is very important, improve significantly the exercise endurance. Those patients can use double the time of exercise if you use tiotropium versus standard care. Now, LAMA versus LABA in those categories, B. Why we did talk about LAMA versus LABA and which one to use first. Again, remember that those patients, exacerbation is not a problem. So, for example, looking at the lung function using tiotropium versus indicatrol at 2 different doses, 150 or 300 microgram once daily, showed that from day 1 to 6 months, all 2 drugs, tiotropium and indicatrol, were far superior than placebo, but there was no significant difference, not statistically difference, if you look at the lung function between the 2 drugs. What about the dyspnea index? Again, looking at dyspnea index comparing indicatrol versus tiotropium, it seems that indicatrol, at least on the high dose, does faster job. At about 3 months, there was better improvement in the indicatrol high dose than lower dose or tiotropium. But if you continue treatment for basically 6 months or so, tiotropium and the 2 doses of indicatrol were of a similar efficacy. And again, we were always saying that with the tiotropium and similar drug, you need some time to deflate the lung, to reduce the RV and the residual functional capacity to get the better outcome. So nevertheless, this basically paper showed continuation of treatment with tiotropium or LABA had similar effects on lung function and on the dyspnea index. And again, exacerbation was not different in these groups because probably exacerbation is not a main problem when it comes to basically category A or B. What about category C and D? Now we're shifting gear to those categories where you have more exacerbation, and now the studies would address exacerbation at the primary endline. And looking at the data or the recommendation by the GOLD at those who are in category C, the recommendation that you either use LAMA or tiotropium to a great extent as a monotherapy, or you use a combination of LABA and inhaled steroid, but not LABA alone, because exacerbation here now is a problem. Or you can have LAMA and LABA. When you go to category D, again, you have the same recommendation, either LAMA as a monotherapy or tiotropium as a monotherapy, or a combination of LABA and inhaled steroid, or you can lump everything in very severe cases, including the phosphodiesterase 4 inhibitors. And here is the data that supported this recommendation by the guidelines. Again, if you look in the uplift study in those patients who were having severe COPD and they were on background treatment, adding tiotropium lead to 14% reduction in all exacerbation, and especially in those who require hospitalization. And the total basically reduction in exacerbation in those patients were about 34%, very significant drop in the exacerbation rate. But why we are saying LAMA as a monotherapy versus LABA inhaled steroid? Because when you look at the POET COPD trial, addressing head-to-head between LABA and LAMA, that was tiotropium versus solmetrol, and this was a 1-year study addressing those patients. It was clear that tiotropium was superior than LABA in decreasing exacerbation by about 30%. So we kind of, based on this data, saying that LABA alone is not as good as LAMA in decreasing the exacerbation. The Invigorate basically trial look at different LABA, which is the indicatrol, compared to tiotropium, and again this was a 1-year study. Now in those patients who have a severe form of COPD, when you look at the lung function, that was the primary endpoint, you can see that tiotropium was superior than indicatrol 150 microgram when it comes to the lung function. Starting from very early till the end of the study, there was quite a significant improvement in the FEV1 in those patients. But I think this was only for the FDA approval. We know that as a physician, FDA lung function is not important that much in COPD. But this is what is important. It is the exacerbation. So, thank you.
Actually, the competitors of Boehringer, your scheduled time 30 minutes, but competitors of Boehringer Ingelheim play in this laptop.
So that is the important, not the lung function, it's the exacerbation. So it's based on this data that tiotropium is superior than indicatrol 150 microgram when it comes to exacerbation by about 1 in every 5 patients. What about the combination of LAMA versus inhaled steroid LABA, where the guidelines say either one is okay? And I think it's based on this kind of data, the INSPIRED study, where patients, COPD patients who were given oral steroid for 2 weeks just to stabilize them, then were randomized to tiotropium as a monotherapy versus seretide high dose as a combination between LABA and inhaled steroid. And they followed them up for 100 days. And as you can see, basically 100 weeks, found that in this case, if you add inhaled steroid to LABA, then you have very similar rate of exacerbation, both mild or severe. So the message is, it seemed that if you compare LABA to LAMA alone, LABA is not enough in a severe COPD. It's maybe as good as in the mild COPD, but you need inhaled steroid with LABA to get comparable result to LAMA as a monotherapy. And of course, this is an endless way of talk and debates. You can find people supporting inhaled steroids, people do not support it. Because of this, it is the imbalance between the risk versus the benefit. And if you look at the different studies, really showed, if you look at the randomized control trial, it seemed that steroid is not very safe in those patients. The inhaled steroid, it can increase risk of pneumonia, skin bruising, diabetes risk, candidiasis, and an observational study, even there was some observational data of increased fracture, basically vertebral fracture and osteoporosis in those patients. And again, the studies are very controversial between effect on exacerbation. Some studies showed, yes, it does. Some studies showed no effect. But nevertheless, still the guidelines say, yes, if you have category C or D COPD, probably it's better to combine inhaled steroid and LABA or to use LAMA as a monotherapy. So if you look at this based on the GOLD guidelines, A and B, there is certainly no steroid. When you go to C and D, you can combine inhaled steroid with LABA in both categories, or you use LAMA as the first-line treatment alone. I'm sure you are probably aware of the CHEST paper that just came last week, again favoring inhaled steroid LABA combination. But I think this is one of the studies that will be in the circle of this controversy. So my take-home message to you, ladies and gentlemen, that clinical studies have proven that the main burden of COPD comes really from the exacerbation and the frequency of the exacerbation, not only from the financial point of view, but also from the quality of life, from the rapid loss of lung function, and also from mortality. I've shown you data that tiotropium, or long-acting anticholinergic drug, they are the drug of choice when it comes to the milder form of COPD. They are probably as effective as LABA in this, and this is why the guideline give you the option. But when it comes to the more severe form of the COPD, or category C or D, where you have frequent exacerbation, it seems that basically LAMA or tiotropium is the only drug that stand alone that can be treated as monotherapy, where all other drugs, they need to have really combination therapy. So yes, in category B, then you can have LAMA or LABA, but once you go to C and D, you should decide between monotherapy of LAMA versus a combination treatment. Thank you very much for your attention.
Thank you so much, Professor Magdi. I know there is a lot of question, but we still have the session at the end of this day with 3 speakers, where if we finish at the allocated time, I mean after an hour, ده هيبقى بعد صلاة المغرب، يعني مش هيبقى غدا، هيبقى فطار. والاستاذ الدكتور مجدي موجود في اللانش اللي يحب يساله، فانا بعتذر ان احنا لازم نبروسيد للسكند سيشن. قبل ما نبروسيد للسكند سيشن، استاذ الدكتور طارق صفوت، الريكوجنيشن للجمعيه لا ينتهي يا دكتور مجدي، بس ده سيمبل بسيط من الجمعيه، لان حضرتك مش هتبقى موجود في الجاله دي، بنسافر بكره ان شاء الله.